Onc Live Insights is a video editorial program produced by Onc Live.
So I think the best patient that can potentially benefit from the combination of Velcade and Feridac or Velcade and panobinostat is that, and again, where the FDA label is, because that's really where we see the largest magnitude of benefit. We see a hazard ratio of 0.5 and an 8-month improvement in progression-free survival. So those are those patients who had bortezomib and lenalidomide, and they're more than 2 lines of therapy. So if we think about what patient selection or patients that would look like, for example, that would be the patient that goes for transplant. They're going to have some induction therapy with likely Velcade Revdex or Velcade Cytoxan Dex, which are the most common induction therapies. Transplant, potentially lenalidomide maintenance, and then when they progress on lenalidomide, we may intensify their lenalidomide to full dose lenalidomide and add in dexamethasone. So at that time, when they progress, this patient will have been exposed to prior bortezomib, sensitive to prior bortezomib, and then had prior lenalidomide. And so in that patient population, I think that's a very important combination to consider because you've already demonstrated that they're Velcade sensitive or naive at that point in time, or correction Velcade sensitive. I think that'd be a good patient to consider for combination. And then again, in that patient who's lenalidomide refractory at that time, the current data that we have now with the excitement with Aspire and Eloquent wouldn't really apply at that time, so then you have to really consider to use other novel therapies. I think this becomes very important to consider in that setting as well, where we can use a combination of Velcade and panobinostat. For the non-transplant eligible patient, oftentimes, at least in the US, the most common approach for frontline patients can either be triplets with RVD-based therapy currently, and that may change in the future, or Revdex-based therapy based on the first trial. And then second-line therapy will often switch over to a proteasome inhibitor, either carfilzomib or Velcade at that time. And as they progress at that point in time, I think there can be certainly options based on that Panorama 2 experience with Velcade and panobinostat, or if they received pomalidomide after lenalidomide based on some recent data, that might be an option for patients as you try using proteasome inhibitor-based therapy in that third-line setting as well. So I think there's multiple ways that patients will present, but as long as they've had prior bortezomib and lenalidomide-based therapy and sensitive to bortezomib, I think that the Feridac combination can be helpful. Even in patients who are Velcade refractory, we've seen some nice data from the Panorama 2 trial showing nice responses in those patients who are Velcade refractory benefiting from this combination.
When we have to consider the use of panobinostat plus bortezomib plus dexamethasone, it's very important to consider the prior lines of therapy, the efficacy, and the toxicity. And these are key points that we usually do in our clinical activity when we plan a treatment for a relapsed and refractory myeloma patient. In this situation, if we plan to use panobinostat plus bortezomib and dexamethasone, we have, of course, to consider that first, patients had completed treatment with bortezomib and animide. It's very important to evaluate that patients have responded to bortezomib-based combination in the prior treatment, and we consider acceptable partial response or better as a response. And the third important aspect is to consider the toxicity profile. If I plan to give to a patient panobinostat plus bortezomib plus dexamethasone, bortezomib and dexamethasone has had to result in a manageable toxicity profile when he received this combination in the prior line of therapy. The duration of the response is a key aspect to evaluate in the clinical trials and also in the management of our patients. In the clinical trials, I consider the duration of response important because we are going to focus on the patients who really responded to this combination. So this is much more attractive to try to really evaluate what is the efficacy of a specific combination. Outside the clinical trials, in my clinical activity, I have some patients receiving bortezomib for more than 5 or 6 years. And response is sustained, tolerability is perfect, so I can speak only about 2 or 3 patients. Probably this is not very relevant, but they represent clear examples to explain that the treatment can be continued for very prolonged periods of time if tolerability is acceptable.
In terms of the addition of Faradac to Velcade and dexamethasone, I think ideally the best patient, based on the evidence that we have, is a relapse patient, but someone who's not been refractory to prior bortezomib. I think the likelihood of response is greatest if they still maintain some likelihood of response to Velcade with dexamethasone, and that the depth of response and the duration of response is therefore going to be significantly improved by the addition of Faradac. I'd be more inclined also, based on the available evidence, to consider that combination in patients with adverse biological features who may not respond to a doublet or simpler therapy at the time of their relapse. So how we use bortezomib in our practice is predominantly subcutaneous, in fact almost entirely via the subcutaneous route, as I don't think, based on the understanding we have of the toxicity of the drug, one can really justify intravenous usage of the drug. What's more contentious is whether it should be given weekly or bi-weekly. And again, I don't think we can make decisions on that based on good evidence. In our own clinical trial experiences, we have a suggestion that perhaps weekly bortezomib in the induction situation may not be quite as effective as bi-weekly. But generally in our practice, we do pursue a weekly subcutaneous schedule and dosing approach. There are some circumstances where we may initially use a bi-weekly approach, and this may be patients with a very high proliferative tumour burden or patients with renal dysfunction, where we really want to reduce the tumour burden as rapidly as possible. There is still a not unreasonable likelihood with the bi-weekly approach of getting peripheral neuropathy even with subcutaneous administration. So just because we're using it subcutaneously doesn't mean that we can't be or shouldn't be vigilant in terms of watching out for neuropathy. But the other toxicities related to the GI tract, for example, really are ameliorated with the subcutaneous approach.